to your vital areas like your brain and kidneys, you'll constrict your vessels. If I then happily come along and stick a needle in your back and vasodilate all those vessels, you can get really catastrophically low blood pressure. So we have to be very careful that if we're going to do a spinal or top up an epidural on someone who's bleeding, that we're pretty confident that we've definitely filled her with fluid before we come to theatre, replace what she's lost, and that she's hemodynamically stable. And it can be easy to get it wrong. Patient refusal goes without saying, if they don't want it, even if we think it's a great idea. You know, she's twins with severe preeclampsia and cardiac disease all in one. She won't, if she doesn't want it, you know, all we can do is lay out the options for her. If we don't have a single midwife to do one-to-one care for somebody with an epidural, we shouldn't be putting them in. Okay, adverse effects of epidurals. There is an increased risk of instrumental, forceps or avant-twos. In primates, that's a raise from 7% to 14%, so it's significant. So we do have to tell the women about this. Again, nobody's ever said, all right, I won't have one then. Slight increase in your length of second stage. No evidence that it prolongs your first stage at all, but that might surprise you. The epidural site itself may be tender for a few days, but there's no evidence that epidurals cause long-term backache. Lots of things about having a baby cause long-term backache, so your ligaments softening in pregnancy, perhaps being on a delivery bed for quite a long time, or in lithotomy, or going to theatre, but no evidence that epidurals do. We don't see blood pressure falls as frequently as you used to. That's interesting. Failure or an inadequate block in 1 in 8 epidurals. Okay, so the women really need to know this, don't they, because of expectations. So if they go thinking, if we turn up and they're like, right, okay, this is it now, 100%, I'll be totally fine after this, then they're really very upset if they have an epidural that doesn't work or doesn't work well, or it's one-sided, or we end up having to recite it. So we have to make them aware that nothing's definite in life. 1 in 6 of these, your anaesthetist will be coming back, having to adjust it, perhaps having to recite it, perhaps give other drugs down. 1 in 100, the risk of a post-dural puncture headache. You do get a rise in temperature with epidurals, about 0.1 degree per hour that you've got your epidural in for, and you will see that. The thing to remember is that we can't just blame the epidural. So if that temperature gradually rises and it hits your threshold then for having to do blood cultures and all the usual things, we just have to do it anyway. We can't just assume that that's the epidural. Nerve damage. About 1 in 1,000 women who have an epidural will have a temporary numb patch or weak area in the leg or the foot. That is not our fault a lot of the time. That is what we call an obstetric palsy. But if there's a needle in the back, if she's had an epidural, we definitely get the blame for all of those. But even if you don't have epidurals in, you can end up with a bit of a risk of numbness or weakness, just to where the pressure of the baby on various nerves during labour. An epidural abscess. Hello.
Sorry, I thought we were going to have a meeting too.
Do you, how are you? I thought we were meant to have this till today, but maybe not.
Print on tables or semester.
Okay. Sorry, we had this morning as well.
All right, okay, sorry.
Have you got a lot of, there's a room that we're not in, have you need a big room, have you got a lot of
Yeah, there's about 30 odd.
There's room, one of the rooms that we're not in, so it was A1 and 2, 13, but I don't know if that's
How many do we know how many there are? Well, we're not going to be normal now, so
if it doesn't fit, so you've got, I think we're in A1 and 6. If you want to try A1 and 2, I'll try to do that. If you can't, if that doesn't work, you come back and we'll do that.
no, if we can, no.
If not, the one on the second floor should be empty as well. They're two.
So one of the two is that was...
So it's first floor. I'm so sorry about that.
No, there must be a list of time.
Thank you. Thanks.
Right. Direct students if they...
Oh, yes, definitely. So you're going to try A1 and 2 on you, yeah? Okay, thanks. Right. Sorry about that. That's because we've gone late, isn't it? Okay. Abscess we talked about, but very rare, about 1 in 50,000 women. Risks of meningitis, and that's us introducing bugs, so maybe Fumironistis from our nasopharynx or whatever, and it does happen, but very rarely. Hematoma that we mentioned, very rare, about 1 in 170,000. And a total spinal, about 1 in 100,000 women. If you don't know what that is, you will know in a few minutes. So how do you get ready for an epidural? It's a totally aseptic procedure. Is this looking familiar from your hospitals? You'll probably have a trolley. You want the woman to, kit to be able to get her in a good position, all your aseptic stuff, a big drip that's running with some fluids, the drugs that you need, and staff that you need to get going. So what you want her to do is supported to open up that lumbar spine, so to get her to arch that lower back out and not leaning off to the right or the left. You can do it in the lateral position, and again you need to try and arch that lower back out, so knees right up to chest if they're doing it in the lateral position. Okay, and why is that important? So this picture on the left is when somebody's absolutely sat straight up, and that grey, the dark grey is our target area. That's where we've got to try and get through the bone. So that you can see there's not much room on that left side, but if we get somebody nicely positioned in flexion, opening up those spaces, you can see we've probably got nearly double our bullseye there, haven't we, to try and get that needle through those spaces. So that's why you might just think we're being really fussy, but we spend ages trying to get them in the correct position, not leaning over, try and get that back nicely arched. Okay, and then when you've done that first, when we've got it in, we'll give our first dose, the test dose, which is to look for an accidental dural tap. So if I did a dural tap, it might be really obvious. Do you know why it might be obvious if I did it with the needle? I'd get spinal fluid. Okay, so, and an epidural needle, again, look in your packs afterwards, is much bigger than a spinal needle. So it comes out like Niagara Falls. So it might be obvious that I've done a dural tap, but it's not always. So then, once we've threaded the catheter, we do more checks. We try and aspirate spinal fluid back, see if we can get any back. And then we give a test dose. And as a test dose, we give like a similar amount that we would if we were doing a spinal for theatre, because we know what that looks like, we know what the effects look like. So we'd give that similar dose, then we'd wait 5 or 10 minutes. And if we've accidentally done a dural tap, we'll see the effects like a spinal in theatre. So she will be my best friend after about 3 minutes. She'll be like, right, that pain's gone, that's amazing. I'm feeling it's less amazing because it shouldn't have happened that quickly. If it was an epidural, it takes about 15, 20 minutes, doesn't it, to become fully effective. So if she's pain-free after 3 minutes, that's not good. We're already thinking this is a dural tap. That's why they do their first dose, wait, watch, get her to lift her legs, ask about various symptoms, and then give the rest of the dose after that. Okay. And then your hospitals, yeah? So if we do, no, we wouldn't. We'd either take it out and do an epidural again, or, depending on what your policy is in your hospital, we can use it to give them drugs, but only the anaesthetist can use that because that's actually a spinal, it's not an epidural. So we would give a little dose, top up, and then no top-ups by the midwife. We'd have to really label it with about 500 labels saying this is not an epidural, it's a spinal. And as our punishment for doing a dural tap, then we have to do all the top-ups after that. Okay. So we've talked about a spinal. You know now where that different place is for a spinal, yeah, just a bit further on through that dura. Much quicker onset, so good for a caesarean section, forceps delivery, much denser block, so much heavier legs within 5 to 10 minutes. We can give a long-acting opioid, like diamorphine, that we talked about in the caesarean section lecture, and it will wear off. That numbness will be starting to wear off within about 3 hours, but it might take 6 to 8 hours or even a bit longer to fully get your feeling back in your legs. And this is just comparing the two, really, just if you've ever been confused thinking, have they had a spinal or an epidural, or what does it matter? What's the difference? These are the differences here. Okay, so spinal's that one-off. We don't leave anything in the space. It's a one-off injection, in with the needle, inject, out again. Epidural is when we leave the catheter in that space. Just look at the bottom one and remember that for when we get to the complications. So for a spinal, we'd use a pretty small volume of local anaesthetic, about 2.5 to 3 mils. But for an epidural top-up, as you know, we'll use about 15 to 20 mils. So just keep that in your mind. So it's rare that you get a really serious complication with an epidural, but when they do happen, they are potentially life-threatening. So we have to be very careful and know what we're looking for and know what the major complications can be. Are you confident that you know what complications you can get with an epidural? Silence. Okay, good. Well, you will be in the next 10-15 minutes. So let's start off with something not quite so serious, but what would you do if we give the first top-up and your woman becomes hypotensive and there's signs of fetal distress on the CTG? What would you do? What was that? Left lateral, okay, so you're going to change your position. Increase your fluids, she's hypotensive, yeah, good. Get the anaesthetist to come, yeah, and you probably want an obstetrician or your midwife coordinator as well, don't you, to come in with that. Absolutely fine. So get your help, left lateral position and your rapid IV fluids. If I get there and the blood pressure is still low, I'll do a vasopressor, so a drug that will just squeeze those vessels up again because they've got vasodilated with the local anaesthetic. Okay, very good. So, when we're looking at serious complications with an epidural, there's two places that you really don't want your epidural catheter to be. So one of them is that the epidural catheter is actually in a blood vessel rather than just sat in the epidural space. And if we give a top-up down that, we may get local anaesthetic toxicity. Or the epidural catheter might be in the spinal space, so it might actually be in the CSF, in the spinal fluid. Okay. If we've done a dural tap and we haven't recognised it. And if I give a dose down that, then I might get a high or a total spinal. So if you think back to that other slide, if I give a top-up down what I think is an epidural, so I'm giving 15 or 20 mils down it, but actually it's a spinal, whereas normally to get blocked to here I'd only need 2.5 to 3 mils, I'm giving like about 5 times what I'd need for that. So we make the checks, and every time we do a top-up, we aspirate and looking for both blood and CSF when we're aspirating back. And that's what you're doing if you're anywhere that gives midwife top-ups. Okay. So, with a high spinal or a total spinal, it's when you've got a large dose of bupivacaine that you thought was going to the epidural space, but it's actually reached the spinal space. And we've done all those checks at the beginning, but very occasionally what was an epidural can then migrate into the spinal space. Now that doesn't happen very often, but it can do. So, any ideas what you think you might get? So we know what will happen to start with, because we know, you know, like when we do our little tester dose for a spinal, and if we've given a little bit, and then they say, well, actually I'm pain-free, that's brilliant, I love it. What might happen next if I've given a really big dose down that epidural? That again? So you might have a respiratory arrest, you might have a few clues before you get to that stage. Anything else that might make you think? Say again? Headache. They may end up with a headache eventually, but the headache would be delayed. So you wouldn't get an instant headache. That might be the day after or even the day after that if they're going to get it. Yeah. Now that is if it's in a blood vessel. So remember that, it's very easy to get the two confused. So that's local anaesthetic toxicity. Hypotension, yeah. So what it essentially is like a spinal and then some. All right, so it's like the world's biggest spinal. So it starts off just like a normal spinal. Yeah, okay, my pain's gone, feel great. My legs are really heavy, not bothered, my pain's gone, as I said. And then she might go, well, actually, my hands feel a bit tingly and my arms are a bit heavy now. And I'm not sure I can take a deep breath anymore. And then her voice might get really weak. And then we'll get the respiratory arrest, severe hypotension, bradycardia, and cardiac arrest. Okay. All right, what would you do? Emergency buzzer, we love the emergency buzzer. Let's get some help in there. Okay, so there's another emergency happening in the room on the other side of the delivery unit, so it's just you for now. What could you do? Or you and your healthcare assistant, what could you do? ABC. somebody saying there, yeah. So this is the actual crux of the whole thing. All you have to do, because you're never going to be on your own for long, are you? All you have to do is to be able to recognise it, get your help, your emergency buzzer, and start that emergency management. Okay, so if she's unconscious by now, all you have to do is the same thing every time. So we've got the help coming, we're going to shake and shout, look, listen and feel for breath sounds for 10 seconds, aren't you? Open the airway, and then if you've got no breath sounds, you're going to start cardiac compressions. Are you trained to check for a pulse, or do you just go straight for... So if you've checked for a pulse as well, and if you've no pulse or you're not sure, you're going to go straight to CPR. Okay? And that's all you need to do. You don't have to be thinking, oh gosh, what complex treatment do I have to do? All you have to do is recognise that she's had an arrest or near arrest and get that treatment started. Now, if you get there before that, or you're on the ball, you think, gosh, I remember that lecture 5 years ago that we had, and this woman, she's right, so her pain went quickly and now her arms are a bit heavy. I know, I'm going to sit her right up. So that gravity helps. So the gravity then will stop that local anaesthetic going higher and higher up the spinal cord, and that might get you out of all kinds of trouble. So if you sit her up as high as you can, monitor her blood pressure, you're still getting that help, you may just save yourself that whole respiratory arrest and unconscious patient. So airway, we've assessed it, we'll give some oxygen, we've checked that she's breathing, we've checked the circulation, we're going to remember aortic cable compression and get some manual displacement of the uterus, rapid IV fluids, and then when we come, we'll be giving drugs to speed up the heart rate and to squeeze those vessels. So ephedrine and atropine we'll be asking for, which is probably on your epidural trolley. Your atropine will be in your cardiac arrest trolley as well. Okay, so going on to, again, these are the two that everybody gets mixed up. Local anaesthetic toxicity is when too much local anaesthetic has reached your systemic circulation. Either we've accidentally injected directly into a blood vessel, so often that might be if we've threaded the epidural catheter into a vessel instead of just into the epidural space. So all or most of that local anaesthetic is going straight into the woman's bloodstream. What symptoms and signs might we get with that? Did we say tingly lips? Was it before? Yes, so you might get tingly lips. Anything else that you've heard of? Have you ever heard of this before? Okay. Well, you need to know about this, even if you don't do epidurals, because you give lots of local anaesthetic, lots of lignocaine, and you can get it with that as well. So if you happen to put a big whack of lignocaine, the perineum was very bloody, but it can be hard not to inject into a vessel sometimes, can't it? So you need to know what signs and symptoms you should be looking out for. So you get tingling around the lips, or you can do. They might say they've got a weird metallic taste in their mouth, ringing in their ears. They just feel weird. They've got a sense of impending doom. They get like this anxiety and know that something bad's happening before even you do. So you might be like, well, the obs are all fine, what's going on? But take that seriously, because other things you get that with as well, like anaphylaxis. The patient often gets a sense of impending doom before everything starts to go wrong. Agitation, collapse with loss of consciousness, and they might fit then with the local anaesthetic. Arrhythmias, so local anaesthetics are toxic to both your heart and your brain. So they cause seizures and all the weird tingling, taste, hearing things with your brain, and arrhythmias with your heart and myocardial depression. Okay. Do you know what we do for local anaesthetic toxicity? So the woman's now collapsed in front of us. She was complaining of tingling in the lips, ringing in the ears, all of that, and now she's collapsed unconscious. What should we do? Emergency buzzer, like before. Stop injecting if you were. Got some help there, got your arrest trolley. Airway, breathing, circulation, avoid aortic cable compression. See the pattern emerging? So even if you think, oh my God, I can't remember which one it was, I know they're really easy to get mixed up, which one was it, I don't know what I'm doing. Well, it doesn't matter, because you're going to do exactly the same management for each. All you have to do is do these bits well, and your whole team will be there within a couple of minutes, and then you can sort out what you need to do. The other thing that you would want to do is to get the intralipid from your theatre cupboard, and you'll have a chance to talk about this a bit more in your groups afterwards. Okay. So if a woman develops this a few days later, she's got severe backache, not just a bit of backache around the skin, it's coming around the back body in a band, just like all the way around like that. You want to have a good look, see if there's any redness, tenderness, swelling, is it looking infected there, palpate it for pain, check the Bromwich score, we'll teach you how to do that in the next session, and check the block, has she got any numbness there. Monitor a continence for a bladder and a bowels, they are red flag symptoms, we will be blue lighting her right into hospital quickly if this has happened and she's at home in the community. Check her temperature, we're going to be sending bloods for white cell, CRP and blood cultures. What do you think I'm worried might be happening? So this is how an abscess might present. This wouldn't happen on the day of labour or the day of the epidural. This would happen further down the road because that abscess is going to take time to develop. So an epidural abscess, there might be nothing to see, but there might be like a red, boggy swelling there, and she might have signs of sepsis, the temperature, and they get backache and neurological symptoms with it. Don't forget about care of pressure areas. You might think, what? You know, these women are young and fit. This is in a primip. This woman, massive blister on her heel. If we've altered their sensation, haven't we, by putting an epidural in? So you'll just sit in one position because you'll feel comfortable. And if that's for hours and hours, even young, fit women can get pressure sores pretty easily. So make sure every time we're perhaps doing the OBS or we're checking the block that we also get her to move around. Make sure she changes her position. Just going to finish off with headache post-delivery. So in the days after delivery, the woman gets a headache. It's pretty common. Lack of sleep, major life event, stress, anxiety, tension headaches, migraines, post-dural puncture headache. It could be. What things in a headache might make me think, oh, this sounds like it might be a dural puncture headache? Yeah?
Is it if the line down, it's easier?
Yeah, absolutely. Because you're getting the... Because if we put a hole in the dura, you're leaking out spinal fluid out of that, and you get a low pressure headache. And then, so if you don't feel those effects as much if you lay flat, but if you sit up, the pressure goes even lower in your brain, and you get like traction on structures in your brain, giving you a terrible headache. So they often feel better lying flat, worse on sitting up. Lie down, feel a bit better again. Sit up, feel worse again. Okay, so that's one of the good things of differentiating it from other headaches. Okay. Might also have photophobia, neck stiffness, nausea and vomiting, ringing in the ears, tinnitus. Okay, so we give them simple painkillers. Don't need IV fluids, just make sure they're drinking plenty. Straining worsens the headaches, make sure they've got some laxatives if they need it. Caffeine does work, but you have to camp out in Costa the amount that you'd need to actually have a pharmacological effect. And the effect is temporary, you can get rebound headaches afterwards, so we don't treat with caffeine. We'd think about, if it was really severe and simple measures weren't happening, we'd think about an epidural blood patch. Have any of you heard of this or seen it done? So with a really severe headache that we think is due to a dural puncture headache, we then would go back to theatre and aseptically take 20 mils of the woman's own blood and inject it into the epidural space. It sounds like some kind of medieval medicine, doesn't it? But it does actually work. But as you can imagine, it can be quite hard to talk a woman. You know, you go and see her and she's got a terrible headache. You're like, we're really sorry that you've got this off from your epidural. It's a known complication, but we've got a really brilliant idea. We want to do another epidural, but with your own blood to make you feel better. And they're like, God, security. Get this woman away. So sometimes they're not keen. What we also need to make sure is that on that day, if we've got it planned, full blood count and CRP sent to make sure we're not injecting infected blood back in. Wouldn't be a good idea. We wouldn't do it if any signs of infection. We also need to be really careful about heparin. Because if maybe she's been to theatre, had a forceps or had a section, she might be on heparin. And we've had a few at Mary's where we've not realised they've been on heparin and we've done the blood patch, not realising she's had a dose of heparin just a couple of hours before, and that would have put her at risk of a haematoma. So we need to be really careful about communicating between all the different groups that okay? Yeah. Okay. Why don't we have a quick chat about how to give an epidural top-up if you get a chance at the end of your groups. I know not all that many places are using them now. So why don't we go to our next session? I don't know what rooms they're in now. here, yeah, and then we're using the rooms that we were before, not A102, because I've sent that chap up there now. That's really going to upset him. So then I think it's A112 and A116, is that right, for the opioids one? And then it may be that they're in A215, but you might want to sort of go to A112 and A116 on the way just to confirm the room, or if you see Kirsty or Andy or Sharon on the way, just confirm which room they're going to be in. So route one can stay here. Well, I don't know. No, have I actually? I think I've just sent them two one's here, aren't they? Should we send group 4 up to the second floor, A215? So if anyone's group 4, if they want to go with Kirsty, groups 2 and 3 will be 116 and 112.
Emails, I sent you the Google survey link for the post-course test and the feedback all in one Google form.
Oh, feedback.
All that's all in that form, we just need to fill it in at the end. Yeah, you on with that?
Yeah, thank you.
Most of them have to be out of those rooms by 3.
Okay. Sorry.
We're going to meet in Sharon's room.
Which is what? One something.
Yeah, it's very close to the room that we've been in.
Why don't you come into the why don't you come into the first 2 rows for this next bit, and we'll do your final session of the day.
Well, then, can I ask you?
Yeah, of course you can. Yes.
So, why is it called a
A walking or a verbal epidural. So all that means is how dilute the local anaesthetic solution that you're using is. So theoretically, the stuff that we're using could be a mobile epidural as well. Well, exactly, that's what the midwives are going to say there. So what you have to do is be absolutely vigilant about checking the motor block. Oh, thank you. Yeah. It's a bit of a pain. Oh, yes, I didn't have 3. Have you got your forms? Your outline forms? Did I get those with it? Yeah. Thank you. Yeah. Okay. You've got the link for the post? I think it's on my emails, I think, yeah.
That's what the feedback on as well.
Okay, great. All right, lovely. Okay. So some places will use 0.0625%, so you get even less motor block. But theoretically, they could all be mobile epidurals, but you'd need like 2 midwives to make sure that she's not going to stand up and have a bit of weakness we've not realised and fall to the floor. So practically, we haven't done that. Yes. All right. Any other questions from that bit, or should we carry on? You probably get time to sort of consolidate that anyway with what we do now. Have all of you checked the epidural block before? Checking sensory level, checking motor block? Yeah. So, okay. We're all right for finishing at 3, actually. Trying to stress me out, speaking up. Okay, so what I want to do is tell you the theory behind checking your motor block and your sensory block. We'll have a bit of a practice, and then we will finish off with epidural complications and just a case study or 2, and then you'll be finished. And then don't let me let you go without you doing the post-course questionnaire and evaluation. So, a pair of spinal nerves comes off your spinal cord at each vertebral level. So you've got 31 pairs of spinal nerves. At every vertebra, 2 nerves come off. One to the left, one to the right, at each one. And each pair of those spinal nerves supply organs, muscles, and a specific area of skin called a dermatome. So you've heard about dermatomes when you're checking the block, yeah? So this is an amazing system, isn't it? So it means that, so we know what these nerves supply. So it's like a map on the outside of what's happening on the inside. So we know that the uterus is, and the cervix are supplied by nerve roots from T10 to L1. Yeah, that's not all that useful for us to check in the block. But if we then check on the outside, we know that T10 to L1 is from about your belly button down into your groins. So if they have got altered sensation in that area, I know that the nerves to the uterus and cervix are blocked, yeah? Does that make sense? So it's like a map on the outside of what's happening on the inside. So it's brilliant. Then when we get to second stage, as we said before, we want also to get right down to S2 to S4. So that can be a little bit trickier to check. So if you can see there, it's not brilliant, but you can see that you need to be spraying the backs of the heels. So if you spray the backs of the heels, that's S2. And, or you can directly spray the perineum, but if she hasn't got a block and you just spray the perineum, she might not be all that impressed with you. But we should be doing this. So even if, say she's getting towards fully, and she's had a beautifully working epidural, and it's been it's been above T10, it's been perfect, she's been so comfortable. But what we should also be checking as well as the top of the block is the lower level of the block, and making sure that those heels are blocked, because we know the heel equals perineum. Yeah.
So it's the same nerves.
Yeah.
As in, so when you spray the heel and it's numb, it means that area is.
Yes. Or most of the time. So the perineum will be S2 to S4. Now there's nowhere apart from the perineum that's supplied by S3 and S4. So you can't sort of check elsewhere for that. But for S2, your backs of your heels are also supplied by that. Now I sometimes, so if I check the backs of the heels and it's equivocal or I'm not quite sure, or I really need to know whether the perineum's numb, I will say to the woman, right, and now what I've done there, I'm also going to do on your perineum, but just don't go up and start there first, or needs a little bit of warning. So if I go to her and she's fully, and I check, I mean, you'll hate me, because I'll come in the room, and she'll be perfect, she'll be like, this epidural is absolutely perfect. And then I'll spray the heels, or the perineum, and realise that although she's got perfect coverage for first stage, it's definitely not going to work for second stage, because we've not got, that local anaesthetic has not got down to those sacral segments. So I'll be telling her to sit totally bolt upright, right up in the bed, to get the back right up, and either give herself a bolus through the pump, or me give a bolus, or you give a bolus, with her absolutely upright. Because we talked about gravity affecting where the local anaesthetic goes. It's more likely to sink down to those sacral nerve roots if she's sat up. What you absolutely don't want to do ever is top somebody up in lithotomy once they're already pushing. Don't do it. Just don't do it. This is what happened to me when I had my first baby. I tried to get them not to do it, but they did it anyway. So if you're in lithotomy, there's no way, you can't sit up enough, can you? So you're fairly flat on the bed. If you give a top up in that position, it won't reach sacral nerve roots, whatever. So there's just no point giving it. All you're doing is giving extra side effects for no good reason. So if you're going to top up, you need to then get her out of lithotomy, get her absolutely upright and top up in that position, give it 15 minutes and get her back in lithotomy and do that. So whether that's for stitching after she's delivered, or maybe second stage is taking longer than you thought, and she wants to top up, even though even though you started pushing, you still need to get her legs down and get her sat up. So I had an absolutely beautiful block from about here to here with absolutely no perineal pain relief at all. So that's what you want to avoid.
Yeah, a mentor that I was working with,
Yeah.
so she was like in her second hour of active labour. She was a primate.
Yeah.
And she said that the epidural was wearing off, so basically asking for a top-up. And the midwife I was working with was like, it'll be better, you'll push better if you don't have the top-up. So is it...
And what did the woman say?
Well, the woman was like, was just, and she was just carrying on.
Yeah.
She was just carrying on, but then you could see she was in more pain.
Okay.
So,
So any thoughts on this? What would you do, or what would you tell them?
well, you give it because she's requesting for
Okay.
it. But then it was like really hard for me as a student
Yeah,
to
yeah,
be
yeah,
like,
yeah, absolutely.
yeah.
So I say to the midwives, this has gone on since the beginning of time, since the beginning of epidurals anyway, is that it was traditional that the midwives would then allow the epidural to wear off a little bit for second stage. It's very hard to let an epidural wear off just a little bit. So if a woman asks for a top-up and we say no, I think at that point we need to say to the woman, now this might make you a little bit more numb for pushing, but I can feel, if you're not feeling your contractions, I'll feel for them, we'll try and coordinate together and push. Might be a little bit harder for you. Or I cannot give you this top-up. But what that woman needs to know is that that's not going to be easily reversible an hour down the line. Because if we've let that block regress by not topping it up for another hour, it's going to be about down here somewhere. So then if she's like, oh no, too much, I want to top up now, there's absolutely, you're not going to be able to salvage that. So she's going to know that is not a let's just give it a try and see how you go. That means no pain relief for delivery then. And so I would suggest to you that woman has already kind of self-selected as somebody who was quite keen on having some decent pain relief if she went for an epidural. She wasn't just after 2 paracetamol and the birthing pool or a bit of Entonox. She's already gone for a fairly invasive option. To not use it for the most painful part of delivery, I would say, is a tricky ethical decision.
Yeah.
So I think you've just got to be open with the woman and say, if you don't have it now, it's going to be very hard to get back.
Yeah.
You know, it would probably be too late then for me to give you. You'd probably need an anaesthetist back in to give a full top-up. That might take 20 minutes. She's probably delivered by that point. Yeah?
I've got kind of like a similar question. So I had a woman the other day who had fairly good working epidural, but then she progressed really quickly. I didn't realise it. And then she was saying that it was, when we did the spray test, it was just a little bit down here. And then when we examined her, she was like not fully.
Yeah.
She fixed it fully. But the midwife, again, similar sort of thing, was like, oh, what you're feeling is pressure.
Yeah.
Not pain. She wasn't saying it was painful, but she was saying it was uncomfortable.
Okay.
And
So,
so what's the
yeah.
deal with that?
I think again, it's very hard, isn't it? Because different women are different. If they can feel anything, like, oh, you know, and it sometimes you do get that feeling of pressure and bearing down, and that would be good to help you with knowing when to push. But if somebody is interpreting something as pain and they don't have a sacral block, for me, if I was in that room, I would be offering to top up at that stage. And I know that some of my midwife colleagues wouldn't be agreeing with that. But my thoughts are that you've already had this discussion about what do you want from your pain relief a lot earlier on, and she's gone in the fairly invasive group, quite keen for some decent pain relief group earlier.
But for a second, so that
Yeah.
sacral block, should she feel any pressure whatsoever?
Yeah, so you may do, but again, it's like a bit of a tightrope to walk, isn't it? So what the midwives are erring on is saying, well, I want you to be able to feel something, so I'm not going to top you up. But I would say then it's a lot easier to fall off into the pain side. My way, which is probably because I'm not a midwife, is that I would say, well, she wanted good pain relief, even if I give her a top-up now, and it does make her a bit more numb. Maybe she doesn't feel quite as much, but also she's more comfortable and more cooperative with you. And she did ask for this epidural. She didn't ask for it to have loads of pain, she wanted it to work. So I'm probably falling off the tightrope slightly more in the other direction. And although I might have her comfortable, you might be having to intervene more to say, well, actually, you know, can you feel any contraction? Well, no, you may. So ideally, I guess what we'd really like is that she didn't feel pain, but she was just about becoming aware of some pressure. And sometimes it's beautiful and it happens just like that. But it's quite rare. And you're either sacrificing a bit more numbness for a bit more pain. If it's right down the middle, we love it, that's brilliant, but it's quite hard for that to happen. Yeah?
Quite often I've seen anaesthetists say to women that the epidural can't get rid of pressure, you know, if they're having that, a lot of like rectal pressure and things, it'll get rid of your pain, but it can't get rid of that pressure feeling. Is there any...
So, again, what they should be doing is checking that she's actually got, so doing a really good check with the spray, not just about where it's up to, but where it's down to. So checking that she's got a good sacral block. And I'm sometimes discussing with our trainees that, you know, I hate it when I go in the room and a woman's on Entonox. So my feeling is that we should, she's asked for an epidural, she wanted it to work well, let's try and get it to work well. Whether that's me going back, and sometimes we give extra fentanyl down, sometimes we give extra of the mix that's in the bag, sometimes we put something called clonidine down, and sometimes we take it out and replace it. But I think we should be doing that early on, not having somebody in quite a lot of pain, but maybe slightly better than it was, still needing gas and air. It's just, sometimes women feel quite let down by that afterwards, and we'll get complaints in saying, I kept telling them that I had pain. Those doctors come in about 4 times, nothing happened, I was still in pain. So I think we do have to be quite proactive. Sometimes we can't get rid of pressure, and sometimes there's a bit of, it looks like they've got a really good block, but they've got backache, they have got a bit of rectal pressure. Sometimes that's a positional thing, so with the OP baby. But there are things that we could try. So I think we should be at least going through those stages before we come to that conclusion, oh, you're just going to feel this pressure. So we should have gone through a fairly logical progression of all those things that we can try for it. So when we are, there's lots of ways you can check a block. Pinprick, again, not so popular on the women. Light touch, we use cold, and we use the Cryogesic spray where we are, you probably do too. So start on your legs and spray up, so start at your heels really, and then you'll know about your sacral block, and then spray up your leg slowly. A number of times I have to, the trainees will go, where do you feel that? And she'll go, now? But it might have been back there, they've done it that quickly. So nice and slowly, and then you can hone in on where it is. If you think, all right, she said it there, and then I go back a bit, what about there, what about there? And then you get a proper level rather than just stopping where you first did. There's always a bit of a delay in answering, isn't it? Then do it on the other side as well. Have to do it both sides because you can get a unilateral block, or it can be, you know, quite different one side or the other. And note the level at when it feels really cold for them, okay? So she may still feel some cold, but compared to her arm, it's less cold. Because this is a block for pain relief and not full-on caesarean section, they often have some sensation left, but they know it feels different to the arm. So you're kind of comparing the two. And you're writing the upper and the lower levels when
so
you're documenting.
Do you want her, for labour, do you want her to have a non-perineum?
So we want her to have we want her to have a non-perineum, or should we say an analgesic perineum for the second stage. So the numbness is a side effect, isn't it? All we want is that pain relief, but if we block sensory nerves, they also get numb and pain relief at the same time. So for second stage, then you want the perineum to be numb. What have I done with Rachel? Did I? No, totally lost. Okay, so does anyone know where?
Are you looking for this?
No, it was. I had a picture of a woman with. Did you put dermatomes on? Well, I thought it was a man. Don't worry if I haven't. So tell me, you can just tell me instead. Where do you think T10 is? So you often get a chart, don't you, to fill in, so you don't have to remember it all. So where's T10? Belly button, yeah. So remember, T10 is belly button. And that's really useful because it's T10 is the upper limit that we need for first stage, isn't it? So we need their block to be at least at the level of the umbilicus, don't we, for first stage, okay? L1, do you know where L1 is? Yeah, so sort of like the lines of your pants in your groin would be L1. And then, do we know where T4 would be? Nipples, yeah, okay, yeah, good to see you know that. And so if we're going for a section, we want a block up to T4 for caesarean. And you might think, well, why is it that high? It's still uterus, which is only T10 to L1, as we've said before. But when you're doing a section as well, you know, when they like swab out the paracolic gutters, you know, afterwards to get any blood out, they go right deep into the abdomen and they stretch the peritoneum. All that comes from a lot higher nerves. So if we only blocked to T10, we wouldn't be able to do a caesarean. They'd be very uncomfortable. So we need to go right up to T4 for that. Okay, so you're absolutely right with all that. If you're doing top-ups, I mean, it may be slightly different where you work, but we used to say we wouldn't, if you check the block and it's already T8, they shouldn't really be needing another top-up, should they? So we'd say get the anaesthetist to review, don't top them up at that point to get somebody to come in and top it. If they're on infusion and it's T8, it's fine. You know, it's a little bit higher than we need, but it's fine, just carry on as we are. If your block's patchy or it's unequal, so say you check the block and she's got a lovely block this side too, it's T9 on the right, but it's down at L2 or 3 on the left, what might you be able to do for that woman? Anaesthetist in theatre, so they'll come and see her when they're done. Change your position to, yeah, bad side down. So just think gravity, it's always bad side down and the gravity will help. So put her on left side down and then you might improve. You could get her, if she's on a PCEA, to press the button, or if you're allowed to do midwife boluses, give your bolus in that position. And then I still say you should tell the anaesthetist, and we'll, as soon as we're free, we'll come and see that woman and make sure it's worked. Okay. If you get a very high block, you can get problem with Horner's syndrome. Has anyone heard of Horner's syndrome? So if your woman says, oh, I've got a really droopy eyelid and my face feels a bit funny, don't just think she's gone absolutely mental. That might mean that a block is really quite high. So check a block, stop the epidural pump and ask the anaesthetist to come and review. Check the blood pressure as well. Motor block, do you do that when you're doing your... So is that Wythenshawe or St Mary's? Is that both places that you're doing? Great. So they can't help themselves, all right, so they're not allowed to lift the leg. So can you move your feet easily, and then can you bend your leg at the knee, and that's all you need to do, and that's both sides. And that's your Bromwich score. And again, that's either on K2, yeah, is anyone you're using? If it's on the electronic system for St Mary's, or Wythenshawe, if you've got a chart, paper chart. And if you've got your Bromwich score on it, great. So hopefully all of us are a 0 today, free movement of legs and feet. If they can move their knees, but they can freely move their feet, it's a 1. If they can move their feet, but they're unable to flex their knees, okay, that's a 2. And if they can't move their feet or their knees, that's a 3. Okay, so.
How often are we checking the block as supposed to be?
Okay, so where are you doing PCEA where you work, or boluses? Boluses. So we used to say, your protocol might be different, but when we used boluses, we used to check it if the woman needed, so if she was in pain, we'd check the block. We would check it 20 minutes after giving a bolus to check that it's effective, and we would check it on the hour, but your own protocol might be slightly different for where you work. So at St Mary's now we should be checking every hour. Are we doing that? So we should be checking and documenting that every hour.
It's really weird, isn't it? Like, I was at Mary's before. Do you really know what to do it?
We take the midwives and do the child.
Yeah.
Oh really?
Yeah.
Oh,
But not every hour.
No.
do they not? Well, so is it boluses?
No, it's mixed.
Is it?
Okay, so
With the patient control.
yeah.
Oh, but they give themselves the phone.
Yeah.
Yeah.
So they
but
so
then,
they should.
pieces can give bonuses as well.
Yeah, if it's not right.
Yes, yeah. So we can give top-ups over and above that if we need to. But those should be doing it probably more frequently. So it sounds like you're only doing it if there's a problem, but what you also want, so you might have a happily very comfortable woman, but she might have a block that's nearly up here. So that's why we do it every hour, to check it's not too high as well as too low. Yeah. Okay. So if you, I'm sure even if you work at a Stepping Hill, if you ring the anaesthetist and say, you know, the epidural went in 3 hours ago, worked well to start with, now she's got a block, you know, T9 on the right, Alpha on the left, I've just, she's just given herself a bolus in the left lateral position, just wondering if you might come and see it, or I'm just going to see it. Who is this? So, which would be great. We'd love you to do that. Now, we are running short of time. We can either talk through a complication or we can have a quick go at checking the block on each other. What would you like to do? Should we check the block? Yeah, because we've done a little bit about the complications before. If we've got time, we'll be able to do one. So, should we have our first volunteer to the front?
Do you want to check something?
I'm not really going to, you don't have to expose your belly or anything like that. And somebody to check the block. Yeah, shall I hand over to yeah. So who's going to check the block for us? Yeah. Lexel. Doesn't that sound right? Okay, so I want you to act out the block. Okay, how's it? Okay, happy? Yes. Yeah.
So I'm going to start at the sole of your feet.
Very good, very good.
I'm not bad, I'm afraid.
No, but we'll
Okay. Do you feel anything there? Hand on the side. Yeah, on the side, okay. I'm going to go slowly up, okay, and you tell me where you're feeling it. Are you feeling it? All the way up. Yeah. And what about T10 area? And you can feel it all the way up to this side. Okay, so that means that we should probably, for the side that it's not working on, we'll put a wedge on this side. We can do a top up.
Okay.
So that the analgesia, the epidural can go on this side of you. And also, so because it's T10, that's like the. Well, I can feel it below that. You can feel it below there. So she would pop up, but then she also needs to line.
Okay. So which side down? Which do you want to put her?
On her right side.
Okay,
Yeah.
so right side down. So where do you think how would you describe this block to me if I was then on the phone?
Okay, so she can feel up to is it L1? Higher than that. Yeah, you can feel it higher than that. So maybe like T10.
Okay.
Is that right? And then but on this side, but on the right side, she can feel it all.
Okay. Okay. And Bromwich?
So Bromwich. Oh right, yeah. So can you have full movement in your legs? I mean your feet. And so zero.
Yeah. Okay.
Zero.
Yeah. Okay. Brilliant. So you've got a block to T12, or it can be hard to do just single dermatome, especially when we're here. You're not really doing it.
Yeah.
So block to T12 on the left, no discernible block at all on the right. Bromwich score of 0 both sides. And your suggestion is to do a top up in the right position.
Yeah.
Right lateral position, which is perfect. Very good. Anyone else want to do one?
Can I just ask, can you give a top up when someone's lying down in that left lateral or right, or do they need to be?
So again, thinking about gravity, it does alter it, doesn't it? So if we give a top up in the left position, more of it's going to go to the left. So if somebody lies left lateral for a long time, maybe for CTG reasons, we often end up getting a lovely, comfortable left side and nothing on the right.
Totally flat.
Shouldn't be flat.
Just
Oh.
somebody was telling me earlier about a situation where they're just giving a top up about 10 minutes ago, and then the obstetrician came and said, "Oh, we need to do an FBS," but they weren't flat on the side.
Okay.
And she wasn't sure whether that was
Okay.
okay or not, or how long would
Okay,
you ask
so-
before you could put them totally flat.
Okay, so it takes about 20 minutes for that local anaesthetic to fix where it's going to go. So if it's like a few minutes after, you don't really want to be putting it up in lithotomy because that could make it go higher than you need it to. Left lateral might be all right, but you might have to, if they're pretty quick and do it in like 10 minutes or something, then you might have to turn her onto a right, a bit like, on a roasting spit, just to make sure that side gets done as well. But you don't want her absolutely flat. So I'd be less keen to put her in lithotomy just a few minutes after. Just give it a good, if you can, I know we can't always, but a good 15 minutes. Yes, so that should do it. Okay, anyone else want to either act or check a block? Do I get you to do another one? Yeah. Who would like to come check the block then? Come on, go a little bit later.
Daisy. I'm going to check your blog now. So I want you to tell me when you feel it. It's called a stitch. Oh yeah, that's cool. Can I use it?
Yes.
Do you always start?
I do. You'll see lots of people do different things, but if you're going to do it properly, you do it my way. So I would start at the bottom. It doesn't matter really, does it? As long as you've got the top and the lower level. And also, particularly if somebody's had sort of breakthrough pain, you often want to keep going after you've got to cold, in case it's patchy. So sometimes we get blocks where they might go, oh, it's cold here. Oh, actually, that doesn't feel as cold again. And it may be that you've... So then it might make us think that it's not quite in the right place, depending on exactly what the pattern of it is. Or if it's like what we call a window, so she might be really comfortable and just have a little bit here, we'd do the same and put her on that side and give another bolus.
What if they've got like TEDs on? Does that affect the way they feel it or not?
Yeah, so normally I would, well, it is, isn't it? It's hard. It's harder with TEDs on because they're not going to feel it quite the same. And if it's only quite a subtle change, that's going to be difficult. But if you can even, you know, pull it over the heels a bit, you know, if you can get it over the foot so you can spray into the heel and pop it back, and then do from sort of knees up, it might give you an idea. Sometimes they can feel that altered sensation, but you won't quite know if it's TEDs or not. Yeah, how did you do?
So, bring. She's got a block of T4 on both sides and a bunch of three.
Okay, all right. So we were in anything?
No.
Okay. So that may be. So if that may be that she's had a fair few epidural top-ups, and it's still an epidural block, but she's had it in for hours and hours. But she's got a pretty dense block of her motor block, hasn't she? So we'll have to at least be thinking, has this moved? Is this now a spinal? This is what a spinal looks like in theatre, isn't it? When they just can't lift their legs at all. So you'd definitely be getting an anaesthetist to come in.
And then would I try and sit her up?
So sit her up upright. Don't give anything else down the epidural. Stop the pump if she's on a pump. Don't give your top up if you were thinking of giving one. Check the blood pressure regularly. Get your anaesthetist back in there. Does that sound reasonable? Okay, I'm trying to get you this link to do your final are you on a WhatsApp group? If I get one of you to put this on from my phone on there, is that going to work? I think it's just going to be... unless I can get on to, let me see if I can get onto my hospital emails. Well, I need you to do it now, though, is the problem. I can, but it's really long. Do you want me to? Shall I try?
Is it the same? Is it the same one as before?
I think it's a different one. Right, let's try reading it out and see how that goes.
You could type it on there and then we could copy it off the...
Yes, good idea. That is relying on me to get it right, isn't it? Right. Right. So HTTPS.
Does it need to be in capitals?
No,
Okay, another thing.
it is.
Was it?
I don't know, is it? I think it is. Isn't it? /forms. I think that's a little o rather than a 0. Doesn't like it. What? So there's no spaces between those forward slashes. Has anyone got it? Got through on that? No? So forms. Are you in here at 3? Okay, we're just finishing now. Forms.gle / capital W 5.
Oh, is there a / after the GL?
Oh yeah, that'll be it. Yes, sorry. I think the rest of it, is that going now?
Yeah.
JFQ, I thought. Capital MERS, capital N. No? It works. Sorry for doing it this way, I'm just so such a technophobe.
Yeah, it worked.
Hooray! Right, so I'll clear up while we're...
Could I ask a random question?
Yeah, love random questions.
That's
good.
Directly related to epidurals. It's about number one mouth on Labour.
Yeah.
Obviously, different hospitals have different
Yeah.
policies. I know Winslow and Meredith and there's no on that. But I looked up to a consultant anaesthetist in Labour the other day and she was like, give it a jig whatever I want, it's rubbish.
Okay.
So that it's not really...
Okay, so the NICE guidelines are that, if I'm doing a crash GA on somebody, so I would really like them to have not eaten anything for 6 hours and have not had any water for 2 hours.
Yeah.
Okay, obviously, if we have to do something in emergency, we just have to, and we'll do what we call a rapid sequence induction and try and prevent any aspiration. So the NICE guidelines are that you can have isotonic drinks and light diet if you are low risk. So I don't know what, does anyone know what Mary's midwifery led? Do they have a light diet in labour?
Yeah,
Do they? They can do that. So I guess that's what that is, the low risk.
Yeah.
And then if you are higher risk, which may be an induction, it may be having opioids, even if that's just a bit of diamorphine, having a REMI PCA, having an epidural, any other risk factors for complications. Well, she was not strictly telling you the truth then, because the risks were that she may have had to go to...
So is the only risk is that if you had to do GA?
Yes, that's the only reason we're saying. No, it's still a low.
Is it very rare, but still?
Yes, so it's rare. Yeah.
It says till 2 o'clock in this one, so
Right. Did you manage to get on
It's
to
the
that?
same one.
Is it?
Yeah, I guess it's just...
Did it say post this time?
Exactly the same.
Thank you very much.
Thank you. Or can anyone take the register back from yours? Thanks a lot. Thank you.
Thank you. I'll put the lights on it. Oops, sorry.
so increase the size of the text on the less
Nothing is working today. Right.
Sorry. Do that.
So we even fewer people taking the chance to escape. Let's do it on. Okay. So, what I'll do. Right. I still don't have all of the necessary It's good. I thought I'd use a permanent marker then. So, what produces OH? Well, it's JO singlet D. So that's the photolysis rate. Photolysis rate of ozone to produce O singlet D. Sorry, this is a very smelly marker. Shoot. Somebody, oh dear. I've used the wrong marker. She's left. Somebody's left a load of material here. Okay. Can anybody tell me how many more things can go wrong in one lecture? Can't believe it. But this one doesn't work. There you go. That's. I'm almost ready to give up. This just shows you the plot of JO singlet D and the OH concentration. Now you might expect, because most of your production of OH comes from JO singlet D, that your rate of increase of OH concentration should just be proportional to your JO singlet D. In any one environment, under any one VOC to NOx ratio, that is true. But if you have different amounts of termination and propagation, you have different amounts of OH formed from the same amount of JO singlet D. Because you recycle the radicals if there's more NOx, and you terminate the radicals if you're too clean and you haven't got enough NOx. So the slope tells you something about the relative rates. So if you've got JO singlet D against OH, then the slope tells you something about the relative rates of termination and propagation. So, if you look at the JO singlet D rate, that's shown by the blue here, you can also look at the dependence of the hydroperoxy plus organic peroxy radicals on the JO singlet D. And this shows, certainly during the daytime, that your radicals are driven by the radical recycling from the OH formation from JO singlet D. Why have you got HO2 and RO2 radicals at night? Why might you think you have HO2 and RO2 radicals at night, but you don't get OH radicals at night? Okay, so your NO3 radicals can also oxidize organic compounds and get hydroperoxy radicals being formed. So we'll go back to this oxidation by OH in the presence of NOx. So your CO can be oxidized by OH to give you CO2. The hydroperoxy radicals, when you've got NOx, will react with the NO to give you NO2 plus OH. NO2 can photolyze to give you NO, and the oxygen atom will recombine with molecular oxygen to give you ozone. So the net of the net of this chain is CO plus 2O2 gives you CO2 plus ozone. Now compare this, okay? So the net of that, CO plus 2O2 giving you CO2 plus ozone. And the net of this one, this clean conditions, CO plus ozone is CO2 plus oxygen. So you destroy ozone here, and you make ozone here. And that's just by adding some NO. So if you have a very clean environment, you're ozone destroying. If you always have enough NOx, you're ozone creating. If you're in the middle, you neither destroy or produce ozone. And if you look at methane, methane plus OH gives you methyl peroxy, which can react with NO to give you the methoxy. Methoxy plus oxygen gives you formaldehyde plus HO2. HO2 can react with NO to give you NO2. Your NO2 can react to give you an oxygen atom plus an NO, which can recombine to give you ozone. And if you add all of this, methane plus 4 oxygen gives you formaldehyde plus water plus 2 ozone. So you can see whenever you add either CO or methane or any other VOC you just have more complicated peroxy radicals, you will produce ozone. So with NOx and VOCs, the more NOx and the more VOC you add, the more ozone you will generate, if you've got enough VOCs and you've got enough NOx. If you take away the NOx, you will become limited through these reaction channels, and your ozone destruction cycles will take place. And so you become less ozone producing until you have way too little NOx and you become ozone destroying. So you've got this half of the channel where you're losing ozone, this half of the cycle where you're producing NO2 and you can produce ozone. And your net ozone production, if you're really, really, really remote, and you're in Antarctica or something like this, you're going to be an ozone destroying regime, where you've got just enough VOCs, just enough NOx, you're very ozone producing. Where you don't have enough VOCs, and you've got lots and lots of NOx, what happens here? Does anyone know what happens here? Why do you not carry on producing more and more and more ozone? Sorry? Which can react with VOCs? Sorry? What tends to happen actually is your NO2 can be your terminating step. So you've got enough NO2 to start competing for your OH. So NO2 plus OH will be a terminating step and you can produce nitric acid. So your radical propagation, because of your NO, is broken because your NO2 is so high. And that will start competing for your OH concentration. So very, very NOx-rich environments. So this is the chain. So don't forget, this sort of thing is fair for me to ask in exams. That what we've now got, because we no longer just have the termination steps of HO2 plus HO2 and HO2 plus RO2 to form your peroxides, we also have this NO to NO2 step to recycle your HO2 to OH. You form ozone in this step, destroy ozone here. You've got a net destruction every time you terminate. Your RO2 can react into RO in the same way your HO2 can react to OH. Give you alkoxy radicals. Your alkoxy radicals can reform your HO2, and you can carry on this fast radical cycling. So do you have any questions about ozone production and the competition between radical termination and radical propagation? Okay, is it all clear? So let's talk about what happens, what's the fate of NOx. So we know that it plays a vital role in the ozone production. But we also know that both NO and NO2 can react with OH. HONO is nitrous acid, HNO3 is nitric acid. The nitric acid is lost via wet and dry deposition, and it takes about 1 to 2 days to E-fold. So to go down by a factor of 2.7, its E-folding time is about 1 to 2 days. HONO is relatively rapidly photolyzed to reform your NO. But your nitric acid isn't very rapidly photolyzed. But also, HONO is formed on surfaces. So if you've got aerosol particles, or you've got wet leaves, or you've got wet ground, your NO2 can be recycled to, or directly turned to nitric acid and nitrous acid. Which is the most soluble, nitric acid or nitrous acid? Nitric. 50-50 chance, nitric acid is more soluble than nitrous acid. So your nitric acid will stay on your acidified liquid surface, but your HONO will come back as a gas. So one of the ways that you can turn NO2 to reactive HONO is by adsorption and hydrolysis on wet surfaces. Okay, so we know most nitrogen in the atmosphere is molecular nitrogen. 78% of the atmosphere is molecular nitrogen. So that's 99.99% of all nitrogen is just molecular. Nitrous oxide is the most abundant of the rest. So about 310 parts per million. That was a few years ago. It's gone up a bit since then. But it becomes well mixed in the atmosphere because it's of low reactivity relatively. And the rest are your NOY species. So what's NOY? Well, the rest of your oxidized nitrogen is NOY. Well, NOY is NOx plus all of the other. Now I won't, I don't believe, go into the PAN story, but all of the other includes your nitrate radical, your N2O5, your nitric acid, and these strange mixed organic nitrate species, peroxyacyl nitrates. And once you've got all of the oxidized nitrogen out of the way, the rest is ammonia. There are a few amines in the atmosphere, but most of the reduced nitrogen is in the form of ammonia. So here's the sort of budget that you find for nitrogen, for the oxidized nitrogen particularly. So as well as lightning NOx, the primary emissions of N2O from soil emissions from nitrification, denitrification and fertilisers, there's a cycling that leads to a net production of around 6 units if you normalise to 100 units. So this is the net flux of N2O. Biomass burning and fossil fuel consumption lead to around 4, with 2 coming from the oceans. And a lot of this, because it's well mixed, is exported to the stratosphere. How do we get N2O down from the stratosphere in the form of HNO3? Do you remember your stratospheric chemistry that we talked about in the last lectures? So how do you get N2O converted to NOx in the stratosphere and then your HNO3? Well, I'll leave you to look that up because I've taught you this one. I'm not going to go through that again. But there's an interconversion between your N2O and your HNO3. Your HNO3 is one of the inert forms that gets re-exported back down and deposited. And then the N2 flux, fairly constant in the atmosphere, denitrification and fixation, and marine denitrification and fixation, and terrestrial denitrification and fixation.
What are the fluxes of N2O balance? The fluxes of N2O is back on balance, so it looks like a lot on balance.
Right, I've got to invent the answer here. Why do you think it might be unbalanced?
Because it's, the influx is 11.
No. But, so why do you think? What do you think the solution to that is? I see what you're saying there. I've inherited this figure from global. Do you do global biogeochemical cycles? Who did you do? Did you do that with James? Did he cover the net sources and sinks of nitrogen?
But I don't think you covered this.
So, at the moment, that oceans looks very uncertain to me. That ocean flux. It doesn't look very unbalanced. I don't know whether these are measured fluxes and there are question marks in the uncertainties in the balance. Whether there is a net interconversion. There wouldn't be a net interconversion because the lifetime of N2O is too high. Well, if you look at this trend, N2O is increasing. If these are measured values, then they may be using this as an explanation for the reasons that the nitrous oxide is increasing. So the net flux looks as though it's increasing through the Anthropocene, so the anthropogenic era, and that will be from perturbation to the soil emissions and biomass burning, etc. So we do know, and this was something that Paul Crutzen and the guys found in the 70s, that there's a net stratospheric increase because of the perturbation to the soil emissions from the nitrogen. So whether or not there's a net tropospheric increase as well, I don't know.
But if they use this data, then for 100 years there will be 300 teragrams increase, well, which is about a quarter of the reservoir, while the figure didn't show that. There isn't a quarter increase.
So you can imagine if there was no 2, if the oceans was an uncertain source, then you would be talking about a net increase of 1/10 of the reservoir. And it might just be that there is an uncertainty that that's about 9.5, that's about 3.6, this is about... I don't know where the rounding is. I'll come back with an answer from the person that gave me this slide. This was the person who James Allen inherited the Global Biogeochemical Cycles course from. Okay. To be honest, I've not gone through this in detail. I was just getting the idea of presenting this was to give you an idea of the rough magnitude of the sources. Okay? I will come up with an answer for you. And I may come up with another arrow or a revised number. I don't know yet. Did you do anything about the role of the biological processes in the nitrogen cycle? Nitrogen fixation, nitrification, denitrification. So you're aware of the different roles that lead to the net emissions of N2O and NO. Did you know that there was a net NO source from soils? It's something that caused us lots and lots of problems when we went into the field in an environment where we didn't expect very high NO concentrations. So we were expecting to measure lots of NO3. Why did we not measure lots of NO3? This was in a forest canopy, and because there was too much NO, because NO reacts with NO3. We were expecting all of the NOx to be NO2, but there is a direct source of NO from soils. And it tends to come from root nodules, and it's very specific species. Right, see if you can find out where the errors are in the rest of the NOx cycling. I'm sure I've inherited this slide from the same person I inherited the other slide from. So I'm sure you'll find some errors. But essentially, you can see the magnitude of the net NOx and ammonia. So if you go back here, we're talking about 2 billion teragrams of nitrogen and 1,300 teragrams of nitrogen. Whereas here, we're talking about 0.15 and 0.6 teragrams. So much, much smaller fluxes and much, much smaller reservoirs. But nonetheless, this is where most of the atmospheric chemistry is concerned, with the small trace elements of small trace nitrogen. So when we're talking about both the involvement of the nitrogen cycling through both aerosols and the gas phase, we're talking essentially the NOx and ammonia part, the NOx and ammonia fractions of the nitrogen budget. So we're talking about 32 teragrams anthropogenic and about 11 teragrams natural. Most of the natural are actually perturbed, well, you might consider them anthropogenically perturbed natural, because a lot of it is because from agricultural emissions, soil emissions and the like, and animal husbandry that can be influenced by human activity. So there's the summary of the relative magnitudes. And you can see it's dominated by fossil fuel combustion. And this all happens, or the vast majority of it happens at the surface. And almost all of it happens in the northern hemisphere. What's the NOx lifetime in the atmosphere? Of the order of days for NOx, because you're talking about the removal, you're talking about nitric acid, you're talking about the uptake of nitric acid and the NOY species on. Let me just see whether I'm going to cover PAN. There's an exception to PAN. No, I'm not going to cover PAN, so I'll cover that here. 95% of NOx happens or is emitted in the northern hemisphere. Most of the NOx species are oxidized through to nitric acid. So eventually the fate is through to nitric acid. So that's the bleed out of your NOx photostationary states. So your NO gets converted to NO2, NO2 gets photolysed back. But every now and again, some of your NO2 is removed from the OH oxidation to form nitric acid. Your nitric acid gets deposited or taken up onto aerosols as nitrates and gets removed from the system. That happens, you're talking of the order of weeks, week to a few weeks in the troposphere. What might also happen, let's go back to, where did we talk about PANS? What can also happen is you have these peroxyacyl nitrates that are formed. And these are formed from reactions of oxidized intermediates of volatile organic compounds with NO2. And they have the strange behaviour of being very, very temperature dependent. So under normal oxidizing lower tropospheric conditions, the PANS are formed at roughly the same rate as they're lost. But if they're lifted in the atmosphere, the reaction rate to decompose goes down. And so you can transport NOx a long way before it's recycled again and spat out somewhere else where it's not emitted. So you can get long-range transport of NOx in the troposphere from PAN species. But other than PAN species, most of the other species are of the order of a week to 2 weeks lifetime because of the removal through nitric acid. Soil release has got a continental surface source. Biomass burning has got a tropical surface source because most of the burning happens around the equator. And you can see the others. I mean, they're quite obvious, but they're much smaller. So the majority of it is dominated by fossil fuel combustion. And here, 1985 data. What do you think's happened since 1985 to this general picture? Generally, this first of all went down and then went up. Why did it go down and then back up again around Europe? Sorry? It was because of diesel engines being encouraged. So what we did, we thought, okay, we will increase and improve our CO2 emissions by introducing diesel, because diesel is more efficient. You get more miles to the gallon, better fuel economy, and fewer CO2 emissions per unit distance travelled. But what we didn't do was account for the NOx. So first of all, this went down till the early 1990s, but traffic use still went up. And then when we converted across to diesel engines, this went back up. Across the US, it's largely stayed relatively stable with a slight increase until we started exporting a lot of our diesel vehicles across to the US. And China has largely overtaken most of the hotspots in Europe and the US. So generally this picture has stayed the same but intensified with additional expansion in industrial regions across China. But if you actually look at the projected emissions, and again the general pattern hasn't changed much, and look at the NOx, in 1890 there was still industrial NOx around Europe, but prior to that northern and southern hemispheres were very, very similar. But you can see the domination now of the northern hemisphere with respect to NOx. And these standard inventories, the most recent inventories go up to about 2013. And again, what you see is an intensification here, and not very much change over Europe and the US. But going back to our chemistry, where do you think you see most ozone? Looking at these numbers. You don't see much. Urban areas, the NO is normally too high. The NO limits your ozone concentration. Also, you're not in an ozone production regime when you have too much NO2, because you're actually terminating the radical chains. In the rural environment, you're just right. You've got the NOx sources and the VOC sources that mean that you're not NOx limited and you're not VOC limited. In the remote areas, both tropical and marine, you tend to be both, well, certainly NOx limited, and in some of those regions, in remote marine conditions, you're VOC limited as well. So let's forget about the sun. Not a load of NOx being kicked out. And in the absence of photolysis, one of your major sinks for NO2 is reaction with any available ozone. So that forms the nitrate radical. The nitrate radical again reacts very, very rapidly with NO2, and it forms an equilibrium with N2O5. Why does it form an equilibrium with N2O5? What happens? What happens to N2O5? Any idea? Falls apart, thermally unstable. So you form it, and then the temperature breaks it down and it falls back apart to NO2 and NO3. So at 298, the equilibrium is established in about a minute. In the daytime, your NO3 really just doesn't exist because it photolyzes very, very quickly. But your N2O5, in a similar way to NO2 hydrolyzing to HONO, your N2O5 can hydrolyze to nitric acid. And this hydrolysis means that you're left with an acidic solution of NO3. But any of the NO3 that's around at equilibrium with N2O5 at night can react with any hydrocarbon species, any VOCs, and it's a hydrogen abstraction reaction. So hydrogen abstraction, just the removal of hydrogen from an alkane, will leave you with your R group. So this is your alkyl group. And so what did we see before? Well, we saw lots of RO2. So we'll go back. And you can see here that during the daytime, when you've got the photolysis, you see the sum of your HO2 plus RO2 follows your photolysis. But at night time, you've still got some of this sum of HO2 plus RO2. The reason for that is that your hydrogen abstraction from a hydrocarbon here can lead to this formation of R, which can react directly with O2. So the R reacts with molecular oxygen and begins the oxidation process. So this allows you to form nitric acid at night. So if you remember, nitric acid, the other source for nitric acid is OH reaction with NO2. So at night, NO3 plus a VOC can give you nitric acid there. This is a loss route for NOx in the troposphere. Because you form nitric acid, you can remove it. If If you remember, it has a lifetime of a week to 2 weeks. So NO3 plus a VOC going to nitric acid, not only is it just an additional source of nitric acid, it's also a removal source for atmospheric NOx. But also, NO3 reacts very, very well with unsaturated hydrocarbons. So what's an unsaturated hydrocarbon?
There are double bonds, triple bonds.
Double bonds and triple bonds. So what do they normally react? What would they react with in the daytime? They'd react with OH, but not as much as they'd react with ozone. Okay, ozone because it's a much higher concentration. But at night time, they can react with the NO3 radical. So here's another example. This was an old example, but I remember it. This was back in 1995, I believe, when one of the first instruments to measure HO2 plus RO2. And we simultaneously measured the nitrate radical plus HO2 and RO2. And this gives you direct evidence. The fact that you can see nighttime HO2 plus RO2 gives you direct evidence for the participation of the nitrate radical. So the nitrate radical plus a VOC give you RO2. The RO2 can react with NO2 to give you this reservoir species that falls apart, again in the same way as N2O5 falling apart. You can lead to organic peroxides. You get this interconversion between NO3 to NO2 because the RO2 can react to give you an alkoxy radical, and the alkoxy radical can form HO2, etc. So essentially, you start the oxidation chain again. The oxidation chain that you start during the daytime from OH, oxidation of VOCs, you can start with the NO3. What else did you notice from this last part? Okay. Reduces OH at night. There have been, this is hypothesised and it's been measured in laboratory, and there's been tentative evidence for some production of OH at night. Okay, so this gives you a channel for OH production at night. Very, very slight, but it does give you an indication that it does exist. So which of these compounds could you use to give you an indication of the difference in oxidants, or the relative strength of oxidants? How might you use the decay rates of VOCs to give you an indication of which oxidant is important? Well, what you do generally, you look for VOCs that have a common source. And you might look for, say, benzene and toluene. Benzene and toluene tend to be emitted from the same sorts of things. In any one location, your ratio of benzene to toluene should be related to its source. And as you age the benzene and toluene in an air mass, the benzene is more stable and can last for about 5 or 6 days with respect to OH, and your toluene is more reactive with respect to OH. You can look across here and see that neither of them react with ozone, and only toluene reacts with nitrate radical, but it can last a couple of years. So if you measure the rate of change of benzene with respect to toluene, it can give you an indication of how much OH has been in that air mass. So you can get direct measurements of OH plus indirect measurements from ratios of VOCs that have a similar source. So what might you use? I'm just trying to see whether, yeah, you probably could. What might you use to indicate? No, you can't. You can't do it with nitrate radical. Methyl, butane, butene. So I was thinking that you could do the same thing for the nitrate radical for methyl, butene and butene, because they tend to have comparable sources, but they also react with all three oxidants. But this gives you an indication of the lifetime of the VOCs with respect to the different oxidants in the atmosphere. What's dimethyl sulfide? Anyone know? Yep, so what's DMS? Where does it come from? Comes from the ocean. Comes from coccolithophores, sorts of phytoplankton that emit reduced nitrogen into the atmosphere. It's the only marine source of SO2. So therefore, it reacts with a lifetime of about 1.5 days to form sulfuric acid, eventually. So it goes through SO2 to sulfuric acid. And it reacts very, very rapidly with the NO3 radical. So it reacts more quickly at night time than it does in the daytime. To OH. Don't need to go through that. Right. We've covered all the material that you're going to need to cover. Do you all feel like expert atmospheric chemists now? Come on, why don't you? There's not much more. Atmospheric chemistry is still a fairly new field. Okay? Most of the stuff I've presented there wasn't discovered until 20 years ago. Some of the stuff very much more recently. We're still unravelling the complexity of atmospheric oxidation. We kind of understand what we think is most of it, but we're still having lots and lots of new surprises. Where do you think most of the new surprises are? Any idea? Where are the surprises in atmospheric chemistry? VOCs? So what's happening? What happens to VOCs that's surprising? There's lots of them. Yeah, I mean, there's lots and lots of... There are more VOCs than we can measure, but also there is new forms of oxidation. So there are actually channels of oxidation that I haven't taught you because they're just coming out in papers now. There's something called auto-oxidation. Has anyone heard of auto-oxidation? I'm not going to... I won't bother you with the details, but ozone plus terpenes reacts very, very, very rapidly to give you, if you have a C